Good evening. Senior Care and Lifestyles welcomes you to join us for the next 30 minutes. Our topic tonight, little lengthy one, but it is about anxiety, mood, cognitive disorders, depression, and in the elderly population. And our guest this evening is Dr. Daniel Kaplin, and this is a return visit for Dr. Kaplin. Welcome.
Thank you. It's my pleasure.
Okay, Dr. Kaplin practices on Staten Island, and he's a clinical psychologist, and he's a professor at College of Staten Island, and also College in New Jersey.
That's correct.
So welcome to our show, and we have many questions to ask you about these multiple topics.
Beautiful.
What are some of the more common disorders among the aging population?
Sure. The three most prominent disorders within late adulthood are anxiety-based disorders, depression or mood disorders in general, and cognitive-based disorders. Usually we refer to cognitive disorders as neurocognitive or disorders of dementia.
Okay, we're all familiar with that term.
Sure.
Do we know what percentage of the elderly are affected with these disorders?
Yeah. You know, the elderly is actually an overlooked population, which is unfortunate when it comes to mental health. But the numbers are pretty staggering. In general, about 33% of individuals 65 and above have some form of mental illness or another. But the three that we are going to focus on, anxiety disorders range between 3.2% in a given year and 14.2% in a lifetime. Depression is 3.1% in a given year, and across a lifetime, 11.7%. And depression, one statistic that is worthwhile to mention is suicide. When we talk about suicide as a symptom of depression, suicide is the highest in the elderly of all the groups, according to the National Institute of Mental Health. And then cognitive-based disorders such as Alzheimer's, dementia, at 65 years old, it's about 0.6% for male and 0.8% for females. By 85, it jumps all the way up to 11% for male and 14% for females. And by 90, it goes all the way up to 36% in males and 40% in females. So it's a big issue amongst the elderly.
Big numbers.
Sure. They jump up markedly.
Right. At 90, I can't believe that percentage.
Oh, yeah.
But I can understand. Okay, let's talk about some of the symptoms of the anxiety disorder.
Sure. Anxiety disorders are a large class of disorders, which include generalized anxiety disorder, panic disorder, post-traumatic stress disorder, agoraphobia. There are a lot of them. Yes. But to encapsulate them as a class, symptoms include feeling nervous, nauseous, dizzy, trouble relaxing, choking, feeling indigestion, and even sometimes dread or feelings of death. These are common symptoms.
Very good. So some of the psychological interventions used to treat anxiety disorders. So I guess we'll talk about some of the medications.
Sure. So I'd like to talk about psychological interventions and pharmacological, so I'll go into both. So in terms of psychological interventions, the most common one is called cognitive behavioral therapy, and CBT for short. This was created by Aaron Beck, and it really looks at how people think and the thinking affecting behavior. And what the suggestion is that inappropriate thoughts lead to maladaptive behavior. So CBT works to help the client reorganize the thoughts in an adaptive way and move from there. Another variation of therapy is called acceptance and commitment therapy, and this is by Stephen Hayes. And this is a little bit softer. It allows the client to recognize there's a problem, but doesn't push them right away to change. And that's huge, because if you don't gauge your client, they're going to run out very quickly. So accept the problem, not necessarily do anything about it, but when they're ready, you get to commitment, and then obviously acceptance leads to commitment and then change. Other techniques, I'm not going to go into all of them, two more. One is breathing techniques. Progressive muscle relaxation is tremendous for anxiety. So if one were to close their eyes and breathe and focus on the part of the body that is holding the tension, and then when they breathe out, release it, that can be very helpful. And then for stress disorders like post-traumatic stress disorder, there's something called EMDR, eye movement desensitization, and that helps with trauma-based anxiety disorders. So those are psychological treatments. In terms of medicine, there are classes of drugs that work. Some work better than others, and some are more recommended than others. Classic, the SSRIs and SNRIs, which are usually referred to as antidepressants, they work pretty well for anxiety. In fact, they sometimes work better for anxiety than depression. Mm-hmm. But there are others, such as tricyclics, which have more side effects, so they're not prescribed as frequently. And then the one that's most common and prescribed the least is what's called benzodiazepine, or Xanax.
Yes.
And it's recommended to prescribe this for breakthrough anxiety or last resort kind of scenario, because it has abuse potential.
It's a very popular drug other than for what it's meant for.
Sure, 100%.
Mm-hmm.
Yeah.
Some of those drugs do have side effects
Yes.
for our older population. Do they use them last? Do they go to the more gentle drugs first?
Right. So I mentioned that the SSRIs, selective serotonin reuptake inhibitors, they're the most common. These are the ones that you go to first because the side effects are minimal. It's the safest profile of drug. Mm-hmm. So an example of an SSRI might be Lexapro. That's a commonly prescribed drug today. Mm-hmm. But when you move to things like amitriptyline, which is a tricyclic, this has all kinds of cholinergic or stomach-based problems, yes, and diet has to be changed. So these are last resort.
Okay, yeah. That's what I was hoping. Okay, so now we can talk about some mood disorders, mm-hmm, and how they present themselves.
Yeah. The two major classes of mood disorder are major depressive disorder and bipolar disorder. But bipolar disorder is not as commonly diagnosed. So for the sake of this talk, mm-hmm, or discussion, I'm going to focus on unipolar depression or major depression. That's fine. So symptoms of major depression are loss of interest in things that one used to do, such as, let's say a person had a hobby of stamp collecting, mm-hmm, or knitting. All of a sudden they may not want to do it anymore. So that's one symptom. Feeling down, depressed, or often sad is a second one. Lethargy, which is basically loss of energy, right, that happens. Change in appetite. Now, I say change because some people eat more when they're depressed, and some people eat less when they're depressed. Sleep changes. Some people can sleep more, some people can sleep less.
Especially if they're sleeping all day, they're not going to be sleeping all night.
Yeah, so it can affect eating and sleep and even concentration. You know, people can become more distractible and whatnot. And the last one is obviously thoughts of death and suicide. This is of concern because the elderly population has tremendous access to pills.
Yes.
And this is a concern that if they're depressed, it's easy to act on suicidal ideation.
Yeah. Well, with personal experience in the hospital, I can say I haven't had too many cases of the overdose.
That's refreshing.
Sometimes we might not be aware. Somebody will come in, say with, they found them unconscious, and we think it's a heart problem, whatever. Family doesn't want an autopsy, And I mean, I'm sure it could go by undiscovered
Sure.
if it looks like natural. But I really haven't had too many cases of, the older population with overdosing.
Right.
I have the younger to the middle ages more prominence.
Okay, that's refreshing to hear in the hospital.
Is it common, is it very common for the elderly to be affected by anxiety and mood disorders? Is it more common than we realize, the lay people?
Yeah, I mean, there are a lot of people who suffer with mental illness and never seek help. And one of the problems with both anxiety and mood disorders are that they have tremendous amount of physical features. So you may just say, oh, I'm just tired.
Right.
Or I'm just, I'm eating like a bird, I'm not hungry.
Right.
Or in terms of anxiety, they might just say, well, I don't know, I'm having these aches and pains, and it's just normal. But so it's much more common than we know. And actually, anxiety and mood disorders are the two most common disorders that we're talking about in late adulthood. So yeah, not only do we have the rates that I mentioned earlier of going as high as 14.2% in anxiety and 11.7% in depression, but there's the whole host of individuals who never get diagnosed, never get treatment.
Right. Especially if they don't have family prodding them or
Sure.
visiting them. Or my father passed away a little over 2 years ago, but 2 years before that, my mother kept complaining, he's not eating, he's not eating. And he seemed to be okay, but knowing my father, he was very vocal type person. I asked him, are you okay? Yes. Why aren't you eating? I'm eating. She gives me too much. But his appetite was like it went in half and then in half again.
Sure.
You know?
And when you see that, you know there's something going on. Yeah. Any sharp drop in weight or appetite, that's a surefire symptom. And sometimes I'm talking about mental health concerns, but it could also be a sign of a physical problem. So it's always helpful for someone who's aware of this to take a look at it, check in, make sure everything's okay.
Yeah, I did. I took him head to toe, and he was okay for 91. He was, pretty good.
Yeah.
But we knew that there was something going on because he didn't want to eat.
Sure.
I think that's a very common for many different disorders is when
That's
they
right.
lose the appetite and they're lethargic. Just have to pick out the right one.
That's right.
So what psychological interventions do we use to treat the disorders?
Right, so because anxiety and mood-based disorders are so closely related, the similar kinds of treatments I mentioned, such as cognitive behavioral therapy, that's the gold standard for treating depression, because a person who has depression, they'll have distorted thinking or negative thinking about themselves. They'll start to be overly critical. They'll have negative views about the world. They tend to become more cynical, pessimistic. And then they start to become very negative about their future and the outcomes. So working on challenging these false beliefs helps in improving mood. So that's individual therapy. Another good thing with depression is to get people into groups. So here, group therapy is tremendous. And it could be a group simply talking about their issues, or it can be an activity group where everyone comes together and they have a task. Could be quilt making, it could be any kind of group, and that tends to improve mood. Right. Because when people are depressed, they isolate themselves.
Absolutely.
And we're getting them back with people.
What popped into my mind was the daycare centers, senior centers,
Sure.
where you have the large group and they're interacting and they do their knitting, their quilting, the men play their cards, and no matter how grumpy they are at home, when they get there,
That's right.
it's the exchange of information, the camaraderie, and I just think it's such a fabulous thing, is that no one should have to sit home alone you know, and
Yeah.
the day centers are wonderful.
And sometimes people will criticize the senior centers, but I think they have their value, and it's
Definitely have their value,
sure.
definitely.
And in terms of pharmacological treatment or
Yes.
drug-based treatment, they're very commonly given SSRIs and SNRIs. These are pretty safe. So the Lexapro, the Effexor, these kind of drugs are safe. But there is a third kind of drug called an MAOI, which is monoamine oxidase inhibitor. All it is that the chemical in the brain, they block it from being broken down. So that increases this chemical, and it helps. But once again, just like the tricyclics, it tends to have high side effects. So it's the last one to be prescribed.
Yes, and many times when you have the elderly and they are alert and oriented, but have these little mood disorders, they will stop taking that medication if it makes them sick, makes them funny, makes them groggy. They will stop immediately.
And they won't tell you.
And yes, they did not tell me. Yes.
And what happens if that occurs is you'll start to see their behaviors and their mental functioning will decrease, and then you have to look at what's going on there. So yeah.
Yeah. So let's see. Mood or anxiety disorders affect women or men? Which one more often?
Sure. Both anxiety and mood disorders are more common amongst females as well. And there are many reasons why this could be, but I'm going to propose two. One is that females are more open to expressing disorders. So if they're feeling something, they're more likely to go to the doctor.
Or tell their daughter.
Or tell their children, their daughter or whatnot. Males tend to still have this kind of pride, so they will suffer in silence, which is an issue, particularly with depression. So that's one explanation, is that females are more likely to go seek help. And the second one is that both anxiety and depression are issues that go on internally. So the way you tend to react to are physiological symptoms and emotional-based symptoms that occur internally. So when we talk about internalizing disorders, they're more common in females, whereas males tend to have higher rates of externalizing behavior, such as ADHD, so the kid bouncing off the walls, conduct disorder, the kid that's messing with the other kids or rebelling in the classroom, whatnot, or things like antisocial behavior. All of these are manifest outwardly, but the ones that are internally, more common amongst females.
Yes, and what do we do to help these poor ladies?
So what do we do? Number one is to be aware. I think that if you are feeling something, if you are the patient or the person, express it to your children, express it to whoever's around you. But if you're not the person, you see it happening, then gently encourage them to seek help. Bring them to a community mental health center. Bring them somewhere where the next step can occur, because we can't treat them as loved ones. It becomes very difficult, and we're not impartial, and in the end, they just get worse. So gently bring them where they need to go.
Right, and it's very hard, especially when you're in the healthcare field, because my friends would say to me, you can't look at this like it's your parents. What would you do if you were a nurse giving advice?
Right.
But it's very hard to separate.
Yeah, for sure.
Oh, yeah. And, okay, did we do cognitive disorders?
No.
Symptoms?
We didn't cover cognitive-based disorders. So in general, when we talk about cognitive-based disorder, symptoms of them include decreased memory, decreased attention, decreased motor skills, decreased language, decreased planning, and increased aggression. These are the commonly observed symptoms. So for example, if an individual has Alzheimer's, sure, they have issues with memory, but it's not uncommon for them to get on a bus, forget where they're going, and not be able to plan how to get back to where they need to go. And when we talk about cognitive disorders, the two most common Cognitive disorders are Alzheimer's and Parkinson's are the two.
Yeah. Later on, I want to talk a little bit about dementia.
Sure,
that in.
100%.
Okay. Cognitive disorders, what we just talked about, do they come before or during dementia?
So this is a tricky question to answer because cognitive decline, which it's referred to, that occurs before dementia. And there's something called mild cognitive impairment, where the person just feels like, I'm getting a little bit older, I'm getting a little bit more forgetful. I'm not able to do things the way I used to. And then they won't even notice it. They'll just say they'll chalk it up to just aging.
This is the way I am.
But these are cognitive-based disorders, right? These are deficits in memory and things of that nature. But within 7 to 10 years from mild cognitive impairment, you develop a dementia. So the cognitive decline starts well before the diagnosis of dementia.
Yes, I thought so, but some of the psychological interventions that we're going to use to treat the cognitive disorders.
Sure, I think the psychological treatments of dementia are pretty fun, actually. So one of them is what we call cognitive stimulation or cognitive remediation. So this would be activities that require them to pay attention, require them to use memory. So you mentioned card playing.
Yes.
Card playing isn't just a fun activity, it's actually sharpening the mind.
Memory.
Memory planning, etc. The actual game memory where you have to remember, this is used in the clinic to help people have short-term memory and improve it. And then there is software, it's big now, called Luminosity. Have you heard of that?
I heard about that, yes.
Right. So Luminosity is basically brain games. And these brain games are you do these puzzles or whatever, and it sharpens the mind. So that's one. Another one is that sometimes they lose track of time, space, reality. So there's something called reality orientation therapy. And the goal of that is to help them know what day of the week it is, or what city they're in, what state, and all of the issues of orientation. And then the last one, for psychological treatment, people don't even realize the power of yoga, meditation, Tai Chi. These are all things that we've ignored in the research for a long time. But 2 years ago, I went to the Association for Psychological Science. They had an annual convention in Washington, D.C. And I heard one of the researchers present their findings, and they showed brain imaging of people who are longtime yoga yogis. They practice it for 20, 25 years. And what they found was that the brain was larger than the other group, because what happens with cognitive decline or dementia, the brain shrinks, it atrophies. So they retain the functioning. When they did PET scans, which measures firing of brain or activity, these brains were more active. And so yeah, the value of yoga, people don't realize it.
I live in a complex on Staten Island, the Garden Apartments, and I came home one morning, parked my car after working the night shift, and I saw this gentleman, Oriental gentleman, mid-90s, and we have a little playground with a little plot of grass, and there he was every morning doing his thing. And I tried not to disturb him, you know, park my car quietly and get out. And I said, he has to be doing this all of his life. He has to be doing this all of his life. I
had a similar experience for a while. I was at a place called the Hamilton Madison House, which is in Lower Manhattan. And Lower Manhattan has a large concentration of Asians, and it's actually an Asian bicultural center. But I would take the ferry, and then I would walk from the ferry up South Street to the location. And as I'm walking by, right by the Brooklyn Bridge, you would see every morning many people doing Tai Chi. It was very impressive.
I wanted to say a little something about reality orientation. when I say we, healthcare field, we used reality orientation 20, 25, maybe 30 years ago in the nursing home population. And we started verbally, good morning, today's Monday, how are you, blah, blah, blah. And then it progressed to putting up chalkboards in their room, big, huge clocks, because today everybody has a plasma TV in their room, but the clock, but there's a calendar. Today is Monday. It's April the 1st, and this has been going on many, many years in nursing home facilities, and it has reached over to the hospital acute care facility.
That's right.
And if you went into Staten Island Hospital, they have a big board for each patient, the day, the time, the date, the shift. It also has the name of your nurse that's taking care of you, the name of your aide, your physician, what tests are planned for the day.
Wow.
It is very, very informative. I can't give you the, maybe between 25 and 30 inches a board square, but it certainly helps the patient and more so the family, because when they come in, they used to be looking for the nurse. Where's the doctor? I want to know how his blood work was. Was it done? Did he have an x-ray? And now this is all on the board for them to see. It's a great idea.
It's a tremendous idea, because one of the things we realize is that once the memory goes, it goes. So having it in front of you is
helpful reminder.
It's very helpful. And another thing that I've seen happen in hospitals are they actually give a newspaper. Have you seen this in a hospital? That they're starting to give patients newspapers. And this is similar for orientation, that it has the date, it has current events, and it keeps them connected to what's going on in the world in the present state.
Well, I know we have volunteers that go around with the newspaper, but the big seller is candy. That's the big seller. But they do have the newspapers. We do have huge library books. You know, that's all available. But today we try, the patients don't want to stay there too long, and of course it's best for them in, treated, and out, and that's it.
Sure.
But I have to say one more thing is I've been in the psychologist's office a couple of times with different friends, family members, and it's not like it used to be with young to adulthood, middle age. I see the majority is elderly now on Staten Island.
Really?
Yes, I definitely see a change in that age group.
So that's helpful, because there, as I mentioned, I think the last time I came I talked about stigma, and stigma plays a tremendous role, and if there is a change happening, it can only improve the quality of life. With
a show like Senior Care and Lifestyles, educating the public, and we have you to thank for it, and our time is up. So thank you, and we'll look for triple play.
You got it. It would be my pleasure.
Thank you, and good night to our audience.